So, changing tack completely now, I'm very pleased to introduce our next speaker, who will be telling us a new view on an old world problem, something that we have been talking about for many years, TB, and looking at it from a BC perspective. So Dr. Alissa Wright is a Transplant Infectious Disease Specialist at Vancouver General Hospital. She's a clinical assistant professor at UBC. She trained here in BC and then did specialist training in the Mass General in Boston, and now has come back to serve all our transplant communities as well as infectious disease. Thanks very much, Alissa.
Okay, so I'm going to spend the next 30 minutes talking about TB, which is not something I ever thought I would do, doing transplant ID, but it's pretty common here in BC. So I have some disclosures, none of which are relevant to this talk. So the objectives of the next 30 minutes are to talk a little bit about assessing the risk for TB in the post-transplant setting in 3 different scenarios. 1, in the transplant candidate. 2, highlighting some differences between looking at recipients and living donors. And 3, talking a little bit about what we're doing here in BC with deceased donor risk assessment. So I thought I would start with some interactive questions. So we'll see how much I actually have to teach you guys. So you have a 58-year-old gentleman who's assessed in pre-transplant clinic. He's on hemodialysis secondary to diabetes, and he comes from China. No known TB exposures, but did get BCG vaccine. Otherwise feels well. Your pre-transplant testing says the chest x-ray is normal, your TST is negative, but your interferon gamma release assay, the blood test, is positive. So question number 1 is, does this transplant candidate have latent TB? So your choices are, number 1, only the TB skin test should be used. It's negative, the patient doesn't have latent TB. 2, only the IGRA should be used. It's positive, the patient needs treatment for latent TB. 3, only the chest x-ray should be used. It is negative, the patient does not have latent TB. Or 4, no single test determines the true risk. Oh, good. So for the majority of you, I have a head start, and we'll see what I can teach. Can you go back to these slides? So the right answer is 4, and I'll explain why. So why does TB matter in the transplant candidate? Well, compared to a reference group with a positive TB skin test, negative chest x-ray, and no risk factors for TB, solid organ transplant recipients have 20 to 70 times the risk of reactivation. And even if they don't make it all the way to transplant, for those of you who just see patients on dialysis have anywhere from 7 to 50 times the risk of reactivation. So what does that mean in absolute numbers? Well, a group in Italy looked at their solid organ transplant patient population, and they have an intermediate risk in their general population of TB of 18.5 cases per 100,000. In their patient population post-transplant, the number of cases was 512 cases per 100,000. So you can see 10 times increase. If reactivation occurs, it's even more complicated in the solid organ transplant recipients, as they more often have non-pulmonary tuberculosis, multi-organ involvement, and poorer outcomes. So what do we have here in BC? This data is courtesy of BC CDC TB Services, and they looked back in their records from 2005 to 2015, and what they found was that there were 22 cases of TB in transplant recipients. 19 of those were kidney recipients, so this is the largest group with reactivation. The median time to diagnosis post-transplant was 684 days, and almost 60% had disseminated or extrapulmonary disease. And the number 1 risk factor was being born in a high endemic country, and I'll talk a little bit about what that means. And in terms of outcomes, you can see that there are actually 4 who died prior to treatment completion, and 1 patient had graft failure. And even if they didn't have outcomes, up to 30% had drug reactions. So, what should we do when we see pre-transplant candidates in the clinic or when they're on dialysis? So all pre-transplant candidates should undergo some form of TB risk assessment. And the risk assessment, unfortunately, there's no single test that makes the diagnosis of latent TB, which is why the answer is really 4. All patients need to be assessed with a combination of factors. The combination of factors you need to look for are history. That's really important. And the most important history is country of origin or where the patient spent most of their life. You also want to know if they've ever been exposed to TB. I always get surprised when I ask patients. Sometimes patients I think should have no risk have several family members who've had TB. And then you want to know if they've ever had tests for TB in the past and what the results were and what therapy they got. You then need some form of chest imaging, either a CT if your patient happens to have it, or a chest x-ray, just as long as it's good enough to look for prior granulomatous disease, and then a test of TB, which can either be an interferon gamma release assay or a TST. Now, I'm going to say that in the dialysis population, you should know that interferon gamma release assays are actually favored, which is why TB Services has now come out and said for patients initiating dialysis, an IGRA should be sent, and I'll show you the data on why that is. So this is a little bit to just highlight why where you come from is so important. So you can see Canada way down there at the bottom for incidence rates of TB and prevalence rates of TB, number of cases per 100,000 population. We are considered a low endemic country for TB, but if your patient comes from the Philippines, South Africa, China, India, or Russia, you can see the rates are easily 100 times that. And so realistically, if you're in that country, you probably at some point have run into someone with tuberculosis. So let's talk about why interferon gamma release assay or the blood tests that you can send for TB might be a better choice for your dialysis population. There was a systematic review and meta-analysis looking at the sensitivity and specificity of the 3 tests in the dialysis patient population that was published last year. And what they did is they took all of the studies that had the results from a TB skin test or one of the 2 QuantiFERON or the T-spot tests, and they pooled them to get a pooled sensitivity. And so TST is on the bottom there. I don't know if I can point. I can't even. Doesn't work. So TST is on the bottom, and what you can see is that the pooled sensitivity, if you can't make out that number for a TB skin test in predicting TB in dialysis patient population is 30%. The T-spot did a little bit better with a pooled sensitivity of 50%, and the QuantiFERON Gold was about the same at 53%. So essentially the 2 blood tests for TB were the same, but you'll note 50%, not 100%, so certainly not your gold standard test. So the decision to treat a patient for latent TB pre-transplant really needs to be a global risk assessment. And the literature already demonstrates this poor sensitivity of the TB skin test and screening, as most patients who reactivated after transplant had documented prior negative TSTs prior to transplant. So in BC, we're working towards a global algorithm for all of the SOT candidates, and what we're really considering the following indications as indicative of latent TB. Anyone who has a TST more than 5 millimeters, anyone who has a positive interferon gamma release assay, or anyone who has imaging abnormalities consistent with prior granulomatous disease, and the only exception would be if someone had a very strong alternative diagnosis. And we're proposing this knowing that we may actually overtreat some pre-transplant candidates, but we think that's better than missing a few cases and having someone reactivate post-transplant. In terms of treatment, the gold standard is the same for pre-transplant candidates as for everyone else. Isoniazid and B6 for 9 months is still considered the gold standard. So in our proposal, we would prefer patients complete their latent TB treatment before renal transplant. We recognize that's not always possible, but there's several reasons for doing that. So the first is that the risk of reactivation with end-stage renal disease is high enough. You saw the numbers, 7 to 50 times the risk. The second is that the risk of reactivation from the literature, unlike BC where you saw that it was several years out, but typically the highest risk period is that first year after transplant because of all the initial upfront induction immunosuppression and the high maintenance that you initially start out with. So you want to start your drugs post-transplant early, and because you're introducing multiple new medications, if you try and add latent TB therapy into the mix, it often comes out with drug interactions or drug toxicity, and so it makes things more difficult. And the Alberta group demonstrated this when they looked at their numbers. The odds of not completing treatment for latent TB post-transplant were much higher than pre-transplant. And in fact, in their group, 69% of their patients didn't complete the full treatment duration post-transplant versus only 51% if you started it pre-transplant. So some patients may be unable to do therapy pre-transplant. This often comes up with the liver group in particular. So there may be reasons why your patient can't tolerate therapy pre-transplant. If they can't, the recommendation is really that latent TB therapy should be initiated as soon as the patient is stable post-transplant, and ideally within the first month after transplant. If you have patients who are untreated but they have risk factors, so for example, they have a history of contact with someone with TB, but they have completely negative imaging, they have a negative TB skin test or a negative IGRA, and you really don't think they need latent treatment, you still do need to monitor, as a small proportion of those can still go on to reactivate. The second group that really needs monitoring is those who have completed therapy. So latent TB therapy, if you look at the numbers out of all patients who are treated, it's estimated to be about 90% effective, and that's the number that patients are quoted when they're in the clinic and starting therapy. In BC, we currently have an isoniazid resistance rate around 10%, and we've actually already had one patient fail isoniazid because of resistance in the post-transplant setting. So patients who have completed therapy, it still should be something that's on your differential. It should be low down, but still there. And the bigger risk for many of these patients is they often travel back to their home country to visit family, and treatment for TB, once there's no sort of immunity that you develop to TB, so they're at risk of getting reinfected, particularly if they go back to the endemic region and are exposed again. Post-transplant, another group that I haven't mentioned, but that does seem to come up more often in BC than anywhere else, is recipients who have latent TB but do not have documented adequate treatment. Should be reoffered therapy. And the groups that I'm really trying to include here are those who have been transplanted at centers outside of Canada. So any new patient who comes to clinic for a first visit should have a chest x-ray and an IGRA sent. And if they come from an endemic area for TB, they have imaging abnormalities consistent with latent TB and or a positive IGRA, they really should be offered isoniazid prophylaxis. The same goes for if you send an IGRA on a patient post-transplant who was never screened before, as there is a large group running around in BC currently who were never screened. If you find positive IGRA, you should really offer them latent TB therapy. Even if they've been stable for 10, 12 years post-transplant, that risk still exists. Any recipient should be monitored for signs and symptoms, even out of this group, if they don't get offered therapy. So I'll talk next about living donors to just highlight some differences. And again, I'm going to start out with a case. So 45-year-old female with end-stage renal disease, secondary to IgA nephropathy. She does not have any evidence of latent TB, but she has a husband who's willing to donate. The husband's assessed. He's from the Philippines with no known TB exposure, but he has a chest x-ray with pretty classic features of old TB, calcified hilar lymph nodes and fibrotic changes in the right upper lobe. His TST is very strongly positive. And this patient actually accepts latent TB therapy and is 3 months into treatment with isoniazid and vitamin B6. So the question for the group is, will the recipient require treatment after transplant? And your options are, number 1, the recipient will always require therapy after transplant. Number 2, the recipient will not need therapy as long as the donor has been started on treatment. The recipient will need prophylaxis if the donor has not completed therapy. Or 4, the recipient will not need therapy as this donor should not be used. Oh, we have a smattering of answers. Okay. So it's almost a split between the recipient will always need prophylaxis and the recipient will need prophylaxis if the donor has not completed therapy. So back to the slides. So living donor assessment looks very similar to your pre-transplant candidates with a few exceptions. So the first is always to rule out active TB, and in most cases these patients are very healthy, so that's really easy to do. Then you have to go on and look for evidence of latent TB. And again, you're back to your global risk assessment, which relies on history, which is country of origin or where you spent most of your life, any prior exposure to TB, and prior TB tests, results, and therapy. You should get some form of imaging, whether the patient has a CT chest for other reasons or a chest x-ray looking for prior granulomatous disease. The one difference is the bottom, which is a TST or an IGRA. So TST should work well in an otherwise healthy patient who's a potential living donor. The only scenario where an IGRA would really be preferred is if there's a prior history of BCG vaccine. And certainly these patients sort of qualify within BC. There's a number of guidelines about who can undergo IGRA testing without some form of special approval. And people who are either foreign-born or First Nations who have a history of BCG, or even in some cases who don't know what their BCG status is, if they have a positive TST, often they can get an IGRA without difficulty. So when to go to transplant if your living donor has latent TB? So unfortunately, there's really not a lot of data on the safety with different durations of latent TB therapy for the donor. 9 months of isoniazid or B6 is still considered the gold standard if that donor is going to take treatment, and I'll talk a little bit about that on the next slide. But ideally, you want them to complete the entire course, or else your recipient should be offered treatment as well. So the only abstract that I've ever sort of found addressing this question was one from 1992, and I didn't see a full publication. And basically, it was a US-based study, and they had 6 planned living-related donors with TB skin tests that were greater than 10 millimeters, and who all had normal chest x-rays, so no evidence. And they didn't talk about what these donors' risk factors were for TB, so I don't know how likely or strongly they felt these TB skin tests were true positives. These donors all received isoniazid for 3 months and then donated their kidney, and the abstract said the recipients were well at about 42 months after transplant without evidence of reactivation and without being given prophylaxis. So that's not exactly the strongest data set. And the estimates in the clinic when you start latent TB therapy is that your risk of reactivation sort of drops 10% per month, but it's not entirely predictable. And so the farther your donor gets into treatment, the better, but you still do have a residual risk of reactivation, which is why we're saying really your donor should fully complete therapy if they are going to do it. So I know there are clinical circumstances when you can't delay for reasons, particularly with preemptive living donations. So when clinical circumstances dictate that you need to do the transplant sooner, the donation need not be delayed. You can go ahead and then just offer your recipient prophylaxis. The second suggestion, or the second issue, is when donors don't want to do latent TB therapies. So there are some ethical issues around making an otherwise healthy person who may not want treatment for latent TB or need treatment for latent TB at that point in time. The TB medications do have a small but significant risk of toxicity, and so you don't want your donors to get into problems as a result of medication that they only need because they're going to donate. So In BC, the recipients should be given prophylaxis if the donor has not completed treatment, which is 9 months of isoniazid and B6, and no prophylaxis needs to be offered if the donor has completed therapy. So that's the living donors. My final group is deceased donors, and so my third question is around a 55-year-old gentleman with end-stage renal disease who gets admitted to hospital with a subarachnoid hemorrhage, and he ultimately goes on to be considered brain death. The family wants to donate. This is a case I saw in Boston, and the patient had been undergoing workup for a renal transplant prior to admission to hospital and had immigrated a number of years ago. It wasn't from India. I changed a number of these details, but essentially he was already known to have a pre-transplant TB skin test that was positive. The chest x-ray in this case, I've given you evidence of old TB with a right upper lobe granuloma, and the current CT chest confirms that right upper lobe granuloma and doesn't show any infiltrate indicative of active TB. The patient died prior to initiation of LTBI therapy. So, which of the following is true with regards to deceased donors? Number 1, it is currently uncertain whether IGRA has a role in deceased donors. 2, the TST is the best test for deceased donors. 3, biopsy and/or cultures should not be taken from this donor to help with post-transplant management. Or 4, this donation cannot proceed because the donor has latent TB therapy or latent TB infection. Okay. Most people. Okay, interesting. So large proportion of you say, number 1, that it's currently unknown where IGRA fits in deceased donors, and then a small proportion say this donor should not be used. So we'll go back to the slides. The right answer is, or the answer that I was going for was number 1, the IGRA. Although you can debate about whether or not the donor should be used, particularly for lungs. So in terms of deceased donors, it's really hard to evaluate these patients. First of all, your information is often incomplete or very limited because you're getting it from a family member or a substitute decision maker, or there may not be anyone to provide you any sort of history. And you really do have limited time to collect the information and do the testing before the donation has to go forward. So the easiest thing is probably to rule out active TB, and then you have to go looking for evidence of latent TB infection. So you still should do some form of history, and here in BC we do ask about travel and some prior testing for TB. You can also often get country of origin, and then you need some form of chest imaging. Sometimes that might just be a chest x-ray, but if the lungs are going to be used, you might get a CT chest as well. So this question of what form of testing, though, you'll notice number 3 was gone. There was no TST or IGRA written down in terms of what you can do. And why is that? Well, TB skin test is completely impractical. You have to plant it and then read it 2 days later. By the time you did that, your donor, you might not be able to use your donor, and your results, there's no way you can wait that long. So people have been interested in looking at whether you can use interferon gamma release assays, as it's a one-time blood test and your answer should come back. So there's 2 sort of studies, and I've taken the bigger one of the 2. This one was published in 2015, and they looked at 105 donors in Germany. And what they did was they did 3 different tests. So they did, on your left, they have the ELISA, enzyme-linked immunosorbent assay. Here in BC, that's the quantiferon golden tube assay. In the middle, you have an ELISpot, which is the T-spot test, and then they did flow cytometry. And they stimulated their donor lymphocytes with 2 different options. The first was the PPD, the tuberculin skin test. So they took the protein from that and stimulated the cells to see if they got a response. And then they used also the typical TB proteins used in these tests, which are 2 ESAT6 and CFP10. And what you find is that when you run quantiferon golden tube assays, what you'll see is that you get some positives, 13, some negatives, 36, but you get the biggest group is indeterminate tests. You can't make heads or tails whether it's positive or negative, and that's been found in another study that was done in Saudi Arabia. You'll see on the bottom, so for the PPD, they got 13 positives, but only 1 positive when they stimulated with TB-specific antigens. For the ELISpot, the T-spot here in BC, they didn't get any indeterminants. They all split into positive and negative. And you'll see on the bottom row there, when they stimulated with the TB proteins, you had a few positives in each of the positive and negative group with the PPD. And then for flow cytometry, you got a few indeterminants, more positives than the ELISA at 21. And 3 positives when you stimulated with TB protein rather than the TB skin test protein. So total, the ELISpot or the T-spot gave you the strongest number of positives. They had about 13% positive rate for TB. Now, they didn't give any of their recipients prophylaxis, and no recipient developed reactivation TB after a median follow-up of 30 months. So it's done in a low incidence country, which is Germany, so it's very hard to tell because there was no gold standard. You don't know how many of these patients had actually seen TB, and they didn't quote any rates specific for their country. So because of this and the other tests, the other paper which was published specifically for quantiferon showing the large number of indeterminants, we're not using any of these tests here. Now, why do you get so many indeterminants with the quantiferon? It's because cell-mediated immunity is really depressed following a head injury. And based on the data, the true positive and negative predictive values of any IGRA are unknown. There's no current gold standard for latent TB diagnosis, and the study had no reactivation, as I mentioned. So at present, we really here in BC are using clinical and imaging-based algorithms. So active TB here in BC would be a contraindication to donation, but if they had a prior history of a positive TB skin test or a positive IGRA, or they had imaging suggestive of exposure to TB and they are from a high incidence country or had other risk factors, we are favoring given latent TB therapy for recipients. Recipients from donors with risk factors but negative imaging or no testing history should be monitored post-transplant with a very low threshold to test. So this is where I'll leave time for a few questions, if there are any.
Thanks, Alissa. There are a few questions, actually, I see here. Does anybody have a question that they want to ask? So looking at the questions that people have written in, first question, is there a way to avoid drug interactions post-transplant or at least manage them?
So probably the easiest way is that you give your patient 9 months of isoniazid. That avoids the drug interactions with the rifabutin or rifampin. If you have to use rifabutin or rifampin, and there are a few patients we've had to do because of exposure to isoniazid resistance, you'll have to dose reduce your TAC, essentially.
And I'll just do one more question for the sake of time. What is the sensitivity of an IGRA test in advanced CKD and dialysis patients?
So that was that systematic review and meta-analysis, 50%. So like a coin toss almost in some instances.
Thank you very much, Alissa, for a very informative talk.